So next, I wanted to talk about some of the common clinical presentations of meningococcal disease. The first part is the meningococcemia, which is the more severe form of the infection. And what you usually see with this presentation is usually rash, vascular damage, disseminated intravascular damage, multi-organ failure, shock, and even death can occur within 24 hours. And this is the more severe form, and it's usually a fatality rate of usually 40%. The second form usually seen is meningitis, and this is the more common form. Some of the common clinical presentations seen is usually fever and headache, which we confuse with flu-like symptoms and makes it difficult to diagnose people with Neisseria. Also seen is nausea, stiff neck, altered mental status, and even seizures. And the fatality rate is not as high as meningococcemia, which is between 3 to 10%. Next, I want to talk about some of the serious outcomes of meningococcal disease that's usually seen. And with meningococcemia, some of the more serious adverse effects seen is skin scars from necrosis, limb loss from gangrene, which I'll show you in the next slide that I have, renal failure, septic arthritis, pneumonia, epiglottitis, pericarditis. And this also has a fatality rate of about 40%. And then the second form is, the serious form is meningitis. The serious form, which is spastic quadriplegia, hearing loss, cerebral infarction, cerebral edema, mental retardation, and hemiparesis. And also has a fatality rate of 3 to 10%. Next is a slide, and it's kind of gross, but I just wanted to make my point across about the infection and what it can cause. And with this picture is seen, it shows that it causes gangrene. Basically, as I talked about, meningococcemia is defined as meningitis in the blood, and is the more aggressive form of meningococcal disease, and has a fatality rate of up to 40%. So the pathophysiology of meningococcemia is variable, but meningococcemia is the most dangerous form when presenting with fulminant septicemia, which is a sudden and rapidly progressive blood infection. Usually patients with this form of disease are in significant danger of obtaining vascular and tissue damage, shock, and gangrene, as shown in this picture. And then second to that, you see disseminated intravascular coagulation. And then meningococcemia could become so severe that it could cause rapid death within 24 hours. This next picture that I wanted to show you is actually ecchymosis. And it's another important sign of meningococcal disease that usually distinguishes it. And it usually starts as pedicate, which manifests as a discrete lesion. It's usually 1 to 2 millimeters in diameter. And where this is usually seen is often on the trunk and lower portions of the body, or even on mucosal surfaces. And then these pedicle regions can actually coalesce and become larger lesions that appear as ecchymotic, as shown on this slide right here. And then this pedicate usually correlate with thrombocytopenia and disseminated intravascular coagulation, which can be an important indicators for bleeding and thrombotic complications. This next slide that I have here I obtained from the New England Journal of Medicine, and it's from the Images in Clinical Medicine. It's actually a photograph depicts of a 15-year-old boy with late-stage meningococcal infection. This patient was identified as suffering from the severe form of meningococcal infection, which is the Waterhouse-Friderichsen syndrome, which is an extreme severe case of meningococcemia that arises with abrupt destruction of the adrenal glands by acute hemorrhaging. Next, I wanted to talk about how you get immunity to meningococcal disease. Immunity is usually obtained through infection, and it's really related to a group-specific antibody that's produced by the body. And immunity is bactericidal and facilitates usually phagocytosis. Usually individuals who are usually at risk in obtaining the infection is usually comprised have compromised immune system and are usually more at risk to getting the disease itself. Usually, serum antibodies are there's more than one that are usually developed within the body, but usually there's also deficits with other serogroups, and that's when problems may arise. Usually, a protective antibody is stimulated by infection through carrier states. Also, as long as how long it takes to obtain immunity, usually it takes a few weeks. And usually it's T-cell independent immune response, so the most primarily antibody that's usually associated with immunity is the IgG2 antibody. However, natural immunization may not require colonization with every serogroup. Usually you just have natural immunization within due to non-pathogenic Neisseria that's also around and are living within your body, and also other genera that are similar to Neisseria meningitidis. Some of the ways that we could actually diagnose Neisseria meningitidis is usually through gram smears of cerebral spinal fluid for meningitis, and usually this is diagnostic. However, a definitive diagnosis is usually by a culture of the cerebral spinal fluid, blood, or skin lesions. And the way that we obtain the Neisseria bacteria is usually it grows on blood or chocolate agar, and it usually requires about 18 hours of incubation. If you wanted to be more specific and try to determine what serogroup Neisseria comes from, it's usually performed by a slide agglutination methods. And this is when there's a reaction taking place between the antigen and an antibody, and once you see that there's an antibody being developed to the antigen, you know that's specific to that bacteria. But usually this is not performed only in serious epidemics. Some of the treatments that we use for Neisseria meningitidis is penicillin, and this is the treatment of choice of infection. The reason why is because this is able to penetrate the cerebral spinal fluid and able to reach the bacteria. However, there's still been extremely rare cases of resistance to penicillin, but it's been very rare that it has been reported. Also, the dosing of penicillin is usually benzyl penicillin 50 mg per kg every 4 hours for 7 days with a maximum of 3 grams a day. And for prophylaxis, usually patients are given ciprofloxacin or rifampin as a way to prevent from even getting the infection. Right now, as I mentioned earlier, the CDC, the best way to prevent the spread of infection is just getting vaccinated. Right now, there are 2 vaccines that are currently available, and they're the quadrivalent. And the first one is the Menomune, which has been available since 1981, and it's a polysaccharide vaccine that protects against serogroups A, C, Y, and W135. The second one that's used, and it's much newer, it's been available since 2005, is the conjugated vaccine, which protects against the same serogroups as A, C, Y, and W135. And Menactra is usually preferred over Menomune because it's conjugated to the diphtheria toxoid protein, which makes it elicit a better immune response. Menactra is currently used for patients ages 2 to 55 years of age. The Menomune should never be used, only in cases where Menactra is unavailable. And nearly 98% of patients who do get vaccinated will reach protective levels within 7 to 10 days. However, with this vaccine, there's rare reports of the Guillain-Barré syndrome, and as of right now, they're still being researched for the serogroup B vaccine because there's nothing available as of right now. So as far as how to control the spread of the infection, as I spoke earlier, the epidemic outbreaks are rare in the United States. However, we still get isolated cases in high school and colleges of someone dying. However, it's still a common problem around the world as far as epidemics. And the way that we are taught that to not to spread the infection is by covering the mouth with tissue when coughing or sneezing. You want to wash your hands more frequently, because one of the ways of spreading the infection is by frequent touching. CDC recommends that the vaccination is the best method of controlling the spread of the infection. So some of the ways that pharmacists actually can get involved in this bacteria is actually counsel patients on medications they're taking and the side effects, whether the patient is infected with the disease or prophylactically with ciprofloxacin or rifampin. I don't know how often they actually administer vaccine patients in retail pharmacies. I'm pretty sure they don't. However, if there's any case, like as in the hospital, if they do administer the meningococcal vaccine to patients, just counsel patients on the adverse effects that's seen regarding the Guillain-Barré syndrome and what to look out for. And these are my references, and if you have any questions for me, I'll take them right now. Thank you.